before we get started, I'm going to go over some different housekeeping items while we let the last-minute stragglers get in their seats. But tonight's course is going to be how early orthodontic treatment can improve the overall health of the patient. This free educational webinar is made possible by OfficeSite, a leading provider of websites and online marketing solutions for dental practices since 2002. OfficeSite is the official website provider of more than 25 plus dental organizations. And I want to personally welcome each of you to the free educational program. The goal really tonight is going to be to educate you and put you and your practice in a position of success for today and tomorrow. So before we begin, a couple technical items. First of all, it's going to be an hour long. It's going to be 45 minutes of lecture from Dr. Rondo, and then we're going to move over to a 10 to 15 minute question and answer session. We do have strong participation, so we've muted the phone lines to eliminate any background noise. The dial-in experience is always the best audio. So you have two options. I recommend dialing in. So if for any reason you have technical issues, call GoToWebinar support or log in, log back out. Keep going. You'll get in. My intent is to record the session, and I am recording the session now. And let's hope that technology cooperates and we get to the end. The questions are so important. This session's all about you. So right now on your screen, take a look, and you got a questions and answer console. So make sure and ask your questions. Ask them right now, ask them throughout the session, and then towards the end of the session, we're going to get to those answers. So that's really the most important thing here, is getting you the information you need in this next hour. In regards to claiming your 1 hour CE course, after the session, I'm going to personally email out a form to each of the attendees, and you'll just have to return that, and I'll give you instructions on where to fax it and where to email it completed, and there will be a test, so that you have to finish that test and get going. So let's go ahead and meet our presenter. Presenting today is going to be Dr. Brock Rondo, and he has been practicing orthodontia for 35 plus years. He's been a client of ours for 10 years, and so we've actually been following his career. He's done quite a nice program. He regularly lectures and teaches 100 days a year, a little bit, maybe a workaholic. He even practices. He's got active practice up in London, Ontario, with more than 700 patients. He's got 5 diplomats, 1 in ortho, 1 in TMJ, 3 in sleep, and he absolutely loves dentistry and orthodontia. So at this point, I'm going to turn it over to Dr. Rondo. Take it away, Dr. Rondo.
Thank you, Don, for inviting me tonight. I really appreciate it. Welcome, everybody. I'm going to cover as much as I can in 3/4 of an hour, and then we're going to take any questions you want, and we can stay longer if you wish. I think my message today is how are we going to increase the size of our practice? I think the number of new patients, or the number of patients, is going to go down compared to the number of new dentists coming on board. And the number of dentists that are presently practicing are retiring much later. And I think we really need to look at something to increase the size of our practice. And I found that I've been doing early orthodontic treatment for children for 35 years, and it's been a great practice builder. It was such a great practice builder that I phased out of general dentistry, and I'm now doing exclusively ortho and some TMD and some sleep. So let's get started. I got some great cases to show you. I think I want to talk about functional appliances tonight in mixed dentition, posterior crossbites, deep overbites, anterior crossbites, open bites, how do you correct an anterior tongue thrust problem, and how to attract new patients. Well, how to attract new patients, you need to get with OfficeSite. I've been with them 10 years, and we've got we're on the first page of Google, and they've really helped me attract new patients, because people will type in orthodontics, London, Ontario, or TMD or sleep, and they'll get me, and we get new patients. And I can honestly say they've been coming to my course for 10 years, haven't had one dentist tell me that they were disappointed with their service. So again, OfficeSite, congratulations. 70% of children have a malocclusion. So that's a huge number of patients in your practice. Huge number. So if you've got a lot of children in your practice, you've got a lot of children that you could help. And the interesting thing is there's a lot of orthodontists that don't do early treatment. And so if the orthodontists in your area aren't doing early treatment, I mean, that makes it easy for you to do it. So I really encourage you to do it. Now, here's a patient with an underdeveloped lower jaw, and you can see here she is after 7 months of treatment, and I brought her jaw forward non-surgically with a functional appliance called a twin block. Hopefully we'll have time to get to that tonight. So the things that we can help with are get rid of mouth breathing, any habits, grinding teeth, any skeletal problems. Now, skeletal problems would be an upper jaw which is very narrow. And that's a bone problem or a skeletal problem. And dental problems are always treated last. We always do the habits first, and we do the bone problems next, and we do the teeth last. And here's a birthday cake of somebody 7 years old who needs orthodontic treatment. So again, now, when we look at a narrow arch like this, we've got two choices. We can either extract bicuspids, or we can develop the arch like we see down here. But I can tell you, it's a lot easier to develop the arch. It improves the breathing. It opens up the nasal airway, makes room for all the permanent teeth, no extractions, and gives you a beautiful broad smile. So I have a tendency to do what the Europeans do in South America, develop those arches, don't extract teeth. Now, in North America, the majority of the orthodontic practitioners do fixed braces and permanent dentition. But in Europe, they treat crooked jaws and they treat crooked arches, develop arches, by developing the arches and doing it non-extraction. So in Europe, it's almost non-extraction, and in North America, a lot of extractions. I'm thinking that maybe it's as high as 60% in a lot of these cases. But if you treat early, you won't have to extract teeth. Now here is William and Kate, and you can see William has a very narrow smile, and Kate has a beautiful broad smile. And there's another picture, and it's particularly this one you can see. Look at the dark corners of his mouth here. He's had bicuspid extractions, and Kate has not. And here's the newest picture of their new baby in People magazine, and you can see he's got a narrow smile. I mean, he's got a beautiful broad smile. And I think what you want to do is make sure you develop the arches and don't extract teeth. Here's another case was treated with just a twin block appliance, an upper and lower functional appliance that fits together 70 degrees, and look at the beautiful profile before and after. Here's another little guy that we used a twin block on and brought his jaw forward. Look at the difference in the profile. I mean, significantly improved his appearance and also brought his jaw forward, which could have eliminated any temporomandibular joint problems. Again, I'll be showing him tonight, brought his jaw forward in about 6 months. Here's another patient brought the jaw forward. I mean, it's easy. These appliances, the appliances do the work. The patient puts the appliance in for 7 months. I check to see if it's bothering the patient, and in 7 months they look like this. And they're very appreciative of the change in their profile. Let's look at Joshua, he's 6 years old. We start a lot of patients at 5 or 6. If they'll wear an appliance, if they'll let me take the impressions, I can do them. So Joshua, the first thing you should do as a general dentist is look at your younger patients and see, are there room for the permanent laterals without extracting the primary cuspids. And you can clearly see that he's got a central incisor going to come in here, but that deciduous lateral is much smaller than the permanent lateral. So you need to develop the arch. He's got traumatic occlusion over here, so we need to develop the arch to get rid of that traumatic occlusion. So when you look at the arch, again, is there room for permanent lateral incisors and 2 centrals without extracting the primary cuspids? And if there's no room, you have to develop the arch. And so that's the simple rule. So the easiest appliance to use, and this has been around since 1935, the Schwartz Appliance, has got 2 pieces of plastic with a midline screw. And all you do is tell a patient to turn that screw twice a week, and that develops the arch, 2 millimeters a month. So there's the appliance, probably been developed for about 3 or 4 months, and a nice broad arch, and you can see now there's room for the lateral incisor over here and room for a lateral incisor here. And the patient did the work. They took the appliance out, adjusted that screw twice a week. So you wear it all the time. You take it out to clean it. You take it out for active sports. You turn the midline screw twice a week, every Wednesday and Saturday, and each turns 1/4 millimeter, and you get 2 millimeters a month, painless. We have all these sample appliances that they can get, so they can choose whatever design they want. Nobody's ever chosen that pink pig yet, but I'm hoping someday they do. And but the American flag is popular, and the golf green, and Snoopy. There's lots of neat colors here for patients. So we make it fun for the children. And you get a separate key like that, and you just turn the screw twice a week. So there's the constricted arch, and there we have room for all the teeth. Now, he never came back. He never came back for treatment because obviously I expanded the arch, made room for all the teeth, and hopefully all the permanent teeth came in correctly, and he didn't need any further treatment. Now, he was also narrow in the lower. So you can see the two permanent central incisors are crossed over. The laterals are blocked out, and so we need to expand the lower arch also. So the lower arch, we put a lower Schwartz appliance in, same thing, midline screw, 2 ball clasps on each side, turn the appliance twice a week. Now it's open 4 millimeters. There it is, and look at that. Look at how the laterals have erupted. The 2 centrals are in, the 2 laterals are in, and isn't that a lovely lower arch? Lots of room for the tongue. He can speak better and make room for all the teeth so you don't have to extract teeth. Mothers and patients don't want extractions. They will find dentists and orthodontists who will expand their arches and avoid extraction of permanent teeth. So it improves nasal breathing, make more room for the permanent teeth. Broader arch, easier to speak, beautiful smile. So again, no room for the laterals. Now there's room for laterals. No room for laterals. There's the laterals. Front, very narrow upper arch. We developed upper and lower arches. It took us probably 3 months of turning the screws and then 6 months to hold. And the patient doesn't have to come in every month. Once they're holding, they can come in every 2 or 3 months. And there's the arch. And he never came back for braces. And I know he would have because I helped the mother with an accident case. She was a TMJ case afterwards. And I helped her, and I know she likes our practice, and she would have come back. But isn't that nice? They spent $2,000 on upper and lower Schwartz appliances, and guess what? No extractions and no phase 2 orthodontic braces. That saved the mother a lot of money. She loves it. Now we have another patient, so that's a posterior crossbite, upper and lower constricted arches. Here's another one. Erin is age 8, and she's got an anterior crossbite right here. And so you can't see this tooth. The upper left central incisor is blocked out and is in crossbite. And look, it looks like the bone here looks like someone took a hammer and made a little hole in her bone here, but it's just because of traumatic occlusion. So again, all we have to do is get that one tooth out of traumatic occlusion. So we have to obviously open the bite because you've got a deep overbite. So we've got to probably put occlusal pads on the appliance, or you can do composite buildups on the primary posterior teeth. So this will be corrected in about 2 months. So again, we just make our upper appliance. She picks a nice color here. We have 1 screw in the front. We have 4 clasps holding it in, usually 2 Adams clasps on the primary molars, 2 Adams clasps on the permanent molars, and she turns that screw twice a week, and there's always an arrow telling you which way to turn it. So the posterior pads are 2 millimeters thick. The bite's open in the front. We turn the screws, and look what's happened. Look at this tooth coming forward, and look at the bone filling in. So the tooth's like this, and 2 or 3 months later, it's just like this, all lined up beautifully. And look at the difference here. Look at the defect in the bone due to the traumatic occlusion, and look at this after about 4 months. I mean, unbelievable. And now we're hoping we have room for those lateral incisors. So there she is, that defect, and there she is fixed. So no braces. All we did was take that tooth out of occlusion. Just move that tooth forward and get rid of the traumatic occlusion, and the bone fills in beautifully. So there it is, and there it is. I mean, unbelievable, so easy. And they actually pay you to do this. And it's very easy. The patient does all the work. I like it where the patient works and the appliance does the work. I don't have to do anything. Just tell them to wear the appliance and turn the screws twice a week. There it is. I mean, what a nice result and so easy. What would you pay for that? I mean, they usually pay around $1,500 for that, and mothers are happy to do it. The nice thing about orthodontics, you don't have to sell orthodontics. I talk almost every weekend to dentists who are taking my courses. I teach 100 days a year. And I always ask them, I said, do you have to sell orthodontics? And they say, no, you don't. You just have to present it. You have a smile like this, you can have a smile like this. And the mothers get out their checkbook and they said, when do we start? With Crown and Bridge, it was different. Crown and Bridge, I had to sell Crown and Bridge. but you don't have to sell this. The mothers want this treatment, and they're very upset when nobody can do it, and they will keep looking till they find someone who can do it. So if you want to add this to your practice, you will have a lot of new patients, and you'll also be able to help a lot of your existing patients. So I think she paid me around $2,000 for that, including the lab fee and the records and the $1,500, $2,000. And what I do is I take that $2,000 off the fee if she needs braces. So she came back to me when all her permanent teeth erupted, and I took the $2,000 off the cost of the braces. I charge about $6,500 for braces in Canada. I know the U.S. fees are a little bit less depending on where you're at, and I just put the brackets on. In 12 months they were straight. So I got $2,000 for phase 1, and I got $4,500 for phase 2, and really the patient ended up looking pretty good. So there she is with crooked teeth, and there she is with straight teeth, and she started like that, and there she ended up like that. I mean, really easy. A straight wire is also very easy. Once you make room for all the teeth, you put the brackets on, it's very easy to line up those teeth. At the very end, we always put a lingo bonded retainer up here to make sure the teeth don't move, and we leave that on for, well, for life. I tell the patient 10 years, but it's really life. And because we don't want those teeth to move. So you can see there she was, and there she is at the end. Look at the beautiful bone situation here. Teeth are nice and straight. Everybody's happy. Weak smile at the beginning, beautiful smile at the end. Gorgeous girl. And you feel very good about doing this every day in your office. I really feel good because the staff do most of the work. In our courses, we train the staff to put the brackets on if your state board allows it, and certainly to change the arch wires, take the records, educate the patients on the functional appliances. Our course for staff is 4 days. The course for the dentist is 8 days. Now, I guess we have a poll now. Do we, Don?
Yes, we actually do. So it's, right now I'm going to launch the first poll. It's on your screen. You should see a nice question. How often do you get requested from orthodontists to extract bicuspids? 2 options, often and never. So please go ahead and fill this out. We got about 20% of the votes in. While we're waiting, just want to again personally thank you on behalf of OfficeSite. For those of you who have not heard about OfficeSite, we're the leading provider of dental websites and internet marketing, and the official website provider for many dental associations. We have web presence packages that include premium website design and hosting, premium patient education with 40+ HD videos. We're about 77% completed with the poll. We got social networking, blog management, local search marketing, mobile websites, and reputation tracking. So it looks like we're stalled out at 78%, which is pretty good. So I'll go ahead and close the poll, and we'll hand it back over to Dr. Rondo, and we're going to review the results at the tail end of the presentation. So stay tuned.
Thank you. Okay, Donald Trump said, success is good, but success with significance is even better. So I think you need to think about your practice and what you're doing for your patients. And I think if you can improve them significantly, like I'm doing with these young patients, I think then when I look back on my practice, when I eventually retire, I think that's what you want. You want to make sure that you were significant. You just didn't show up. You practiced significance with significance. So your patients really appreciate what you do. And I think that's what I like about ortho. They really appreciate what I do. So that's my practice. I have to practice limited to orthodontics, TMD, snoring, sleep apnea. And let's look at Alex. So we looked at, first of all, constricted upper and lower arches, and we showed you how to expand those. The next case had an anterior crossbite and you had to put the pads on the teeth. Now here comes a little 5-year-old guy with an open bite. He's got this huge open bite due to a tongue thrust. Look at this 7mm anterior open bite. Now I can tell you, if you don't fix that, that will not fix itself. If he's putting his tongue between his teeth 2,000 times a day, you're going to have to put a crib in there to stop it. You can't stop that. You got to put a crib in there. So I'll show you for the anterior tongue thrust, we put a crib in there. So and we have to have a expansion screw, and we have to have some sort of a crib at the front. So anyway, there's the crib at the front to try to close the anterior open bite, and that crib goes in. Now a lot of you are probably thinking, wow, do I really want to put that in a little boy? But you know what? They don't mind it, and they can eat, and they can do everything. And we charge them almost $2,000, for that crib. But believe me, wait till you see what happens. So that crib goes in, and you'll see the open bite close down by itself. Okay. In about 2 months, we went from the 7 millimeter anterior open bite to the 3 millimeter anterior open bite. Because when that tongue doesn't go between the teeth just erupt naturally. So again, 7 millimeter anterior open bite. After 2 or 3 months, we got a 3 millimeter anterior open bite. And now we're going to see him when he's about 8 years old. So we started when he was about 5. Here he is with his 8, and his bite is closed down. So there he is at 7. There he is at 8. I mean, that was a pretty nice way to do it. And he only had the crib in for 5 months. The crib was only in for 5 months. That habit can be stopped in 5 months. And again, there he is at age 5. Now here he is at age 12, just to show you that it worked. So here's at age 12, and the bite's closed down. And the mother, said, do we need braces? And I said, how much money do you have? Because really, he's pretty good. And if you have other money and you have other kids in the family, spend the money on the other children because he looks pretty darn good. So again, the neat thing was he was 5 years old. We charged around $19.20, and that includes the records, and that includes the lab fee and all my appointments. And also we check on him every 6 to 12 months at no charge. He didn't need a phase 2, so he did not need orthodontic braces. No braces required. So that was a pretty good investment. And we have a lot of patients when we do phase 2, they don't need phase. We do phase 1 with functional appliances, they don't need phase 2. Again, that's a pretty nice result with just one appliance with an expansion screw and a crib. So there he is. Happy patient, no braces. Pretty nice. And you feel pretty good about that. Because who wants to wear braces for 2 years? And if you hadn't stopped the habit, he would still have an open bite at age 12. And it would affect his speech. So that's, if you are interested in me helping you further, which I'd love to do, you can go on my website, rondoseminars.com, or call us at 877-372-7625. But I'm really glad to have the opportunity to talk to you tonight about all these things. Now, here's Stephen. He's age 11. He's a little older. Now, this guy has headaches. He has a deep overbite and headaches. Something you've got to watch for in your practice is anybody with a deep overbite. A high percentage of females over age 20 have headaches, and even some males less than 20 have headaches. And this guy has headaches. He has this deep overbite. So are you going to leave him? He's 11. Are you going to leave him till he's 13 with headaches and then say, okay, let's treat you? Or are we going to fix the headaches right away? I can fix those headaches right away. What I do is I'm going to put an appliance in called a Ricinator, which I'll show you in a minute, and we're going to do composite buildups on the primary molars. So he's got this deep overbite. He's got a little bit of a class 2 molar relationship, and he's got a very retrognathic profile. When you have a retrognathic profile and you're class 2 molar, you know you've got to move that jaw forward. He's also got a short lower face height. When you have a short lower face height, you have to increase the vertical. You have to bring up the posterior teeth. Now that might be foreign to some of you, because I was talking to someone last week and they told me that their particular orthodontic clinician, doesn't matter who it is, said you can't bring up back teeth. Well, I can tell you I've been doing it for 35 years. I've been erupting back teeth for 35 years, and you can certainly do it. So put in the Ricinator, which I'm going to show you in just a second. It's an anterior bite plate to open up the bite. Then you do composite buildups on the primary molars. So there's composite builds the primary molars, and there's a space between the permanent molars back here. And that permanent molar will passively erupt in 6 months. Sorry, 3 months. That molar will come up in 3 months. Okay, so that's all you do. You put in an anterior bite plate in the front, and you do composite buildups at the side, and let that permanent molar passively erupt. So you'll see that they came right up, and so there's the Ricinator. It's just an anterior bite plate at the front, and you see the wire goes on the inside, so all the teeth can erupt, and you could even do braces at the same time you're doing a Ricinator. So we're just letting all the primary molars come out and all the bicuspids come in. In the meantime, we've corrected his deep overbite. We've corrected his headache. He had an overjet of 4 millimeters. So we're going to bring his jaw forward. There, we brought his jaw forward 3 millimeters. We got rid of the deep overbite. There's the little ramp. He bites in front of that ramp 2,000 times a day. Very comfortable. It's fixed. He can't take it out. And so there he is with headaches, and there he is without headaches. It might take 2 or 3 days to get rid of the headaches. That's right after we put the Rickinator in. So I'm not sure he had no headaches at that time, but in a couple of days the headaches are gone. So there he is with a very retrognathic profile. You can see how this crease under the lower lip. And here he is with the Rickinator in like an hour later. That's how good he can look in an hour. And I did this initially to help patients look better, but then I realized they feel better too, because you get the jaw forward, you help the TMJ, you help the health of the temporomandibular joint, and you get rid of their headaches. I mean, what great gifts. Here he is at the end. But he had braces. I put braces on to finish him. And so there he is. I mean, it worked. The deep bite worked, and he doesn't have a deep bite anymore. He's got a class 1 molar relationship. Again, class 1 molar relationship. He started out class 2, class 1 cuspid relationship, normal overjet overbite. Real easy treatment. So remember, he started out like that with a deep bite and a class 2 molar. He ended up with a class 1 molar and a normal overbite. Again, deep overbite is 6 millimeters. You want to fix this. And it's very easy. I put an anterior bite plate in, the Rickinator, and I did 4 buildups on the posterior teeth. And for that, they probably paid me about $2,000. And again, that price came off, that fee came off when I did the braces. So again, I probably charged $2,000 for phase 1 and $4,500 for phase 2. Really a good case. That's just a dentist or a patient having with a snoring appliance. And I do in-office courses. So here's a dentist who sent me a staff to train them on what we were doing. Let's look at Kyla, 7 years old. Again, an anterior bite plate. Sorry, an anterior open bite. Anterior open bite. No room for lateral incisor. Look, there's no room for lateral here. And that's a deciduous lateral. Probably no room for a lateral in the lower also. Plus an anterior open bite. So we're going to have to put a crib in to stop the habit, and then we're going to have to expand the arches to make room for the laterals. I mean, it's very logical what you have to do. The cause of the open bite is a tongue thrust. So we would get the tonsils out first if the tonsils were causing the tongue thrust. If not, we would go right ahead and put the crib. So there she is. There's no room for a permanent lateral here, and we need to make sure more room here too. So there she is. No room for a lateral there. I think you'll agree. There's no room for a lateral there and a lateral there. So let's develop the arch, but we have to stop the habit first. So the lower arch is also constricted, so we have to expand upper and lower arches. So there's the appliance. That's called a Hyrex screw, which the mother has to turn twice a week. And the arrows tell you how to do it, and we give the patient those instructions. And there's that crib at the front. Again, if you don't have the crib, it's not going to work. So if they won't wear a crib, I won't treat them, because that's the only way we can close the bite down is when you fix the habit. So again, there's the crib. There's the crib, and that'll close in 2 months. 2 months, that bite's closed. Okay, and now we have to leave the crib in, remember, for 5 months, and we have to start expanding the upper arch. So again, the bite closed in 2 months. If you stop the habit, which is the tongue going between the teeth, no problem. So the upper Hyrex screw is open 6 millimeters. We took the crib off after 5 months, and now we're just making room for those lateral incisors. And there we've opened that quite a bit. You can see that's probably over about 10 millimeters. So she's going to have a beautiful broad smile, and she's got room for the laterals. And how much do you expand? When there's room for the laterals, you stop. That's it. And then we have to make the lower match. So the lower is a little constricted, so we have to make room for these incisors without extracting the primary canines. That's it. Make room for all the incisors, no extraction of canines. So there's the lower Hyrex screw. And again, the mother turns that twice a week. It's a very simple little appliance, 2 bands on the molars, Hyrex screw, turn that twice a week. Okay, it's fixed. They can't take it out, so it's guaranteed to work. So if cooperation is a problem, we use a fixed appliance. If they're good cooperators, you can use a removal appliance. Also, look, when we expand that arch, I want you to see what's happening to the tongue. The tongue's coming forward. Now, that will be very important later on in life if that patient puts on weight, especially after menopause. A lot of women snore after menopause. They sometimes put on some weight, and that could help prevent sleep apnea and snoring if you develop the arches at an early age. I honestly think the treatment for snoring and sleep apnea is going to come out soon, that you have to treat the children properly first and avoid the snoring and sleep apnea later. which is a life-threatening condition. We can talk about that another time. Don, if you wanted me to come on sometime and talk about snoring sleep apnea, that's a huge subject now. So again, we lined up those incisors. Look how nice and straight they are now, and we've left the primary canines in. So constricted arch, and now look, there's room for the lateral incisors on the upper, there's room for the lateral incisors on the lower, and of course now the mother's going to say, what about these teeth? I want these teeth straight. So all our cases, we stop the habit first, develop the arch next, make room for all the permanent teeth, and then the next thing we'll do, we'll put braces on just those 4 front teeth on the upper. So we just put a little arch wire in there, and with colored ligature ties, those brackets are $5 or $6 each. Not a big investment. The wire is probably $5 a piece. Not a big investment. And we straighten those teeth. And in 2 months, they're straight. These wires are like magic. The brackets are great. And, of course, we show you how to do this in the courses. Or if you don't take my course, take some course. There's a lot of good courses out there. Take a course and learn how to do this. But hopefully the course you take will teach functional appliances and braces. You want both. You don't want just braces. You don't want just Invisalign. You want everything. Take everything. Okay, so that fee was $3,000. The upper fixed appliance with the tongue crib and a lower fixed appliance and the braces on the upper front teeth, $3,000. The mother was happy to do it. Remember, there was no room here for these lateral incisors. Now, you've seen enough cases. If the upper arch is too narrow, the lateral incisors will become impacted or they'll come in the palate. So why would you wait for that? And also, if you leave this arch like this, the cuspids are going to come in like fangs. So why would you wait for that? Why would you not expand that arch? I expand the arch, the cuspids are going to come in beautifully, and who knows, maybe she'll never need any more treatment. Wouldn't that be nice to spend $3,000 and have no further treatment? And there's the lower arch, expanding the lower arch. We didn't have to put the brace on the lower because they were pretty straight, but braces on the upper, beautiful. So again, that looked like a difficult case, but that's not a difficult case if you treat it correctly. So again, constricted arch, stop the habit, expand the arch, put your brackets on 6 teeth, and you're done. The teeth were straight in 2 or 3 months. Another poll. Okay, what do you got there, Don?
Beautiful. We're going to go, next poll is, do you offer Invisalign treatment? And you should see that on your screen right now, so go ahead and ask and get that answered. But, a lot of times people ask me why Office Site for Web Presence Solutions, and the answer is really simple. The value in what we do is, number one, we're putting you in position to attract the most new patients possible. We're also really keenly focused on securing referrals. So when people get to your practice website, they like what they see. Finally, we're trying to increase that case acceptance with digital HD patient education, hundreds of pages on site. And then finally, just increase office efficiency with simple things like patient forms. Right now, we got 85% of the vote is in. So let's go ahead and I'll turn it back to Dr. Rondo. And when we're done here, we're going to review the results towards the end of the session.
Okay, Don, I've got another patient here. Now, what do you do with a patient who won't wear a removable appliance? You're going to have patients that won't wear removable appliances. Look at this little guy. And the mother makes the decision. I say to the mother, does he do everything you tell him or nothing you tell him? If she says nothing, I tell him he gets fixed appliance. So again, here's a guy with no room for the permanent central and lateral incisors. Okay? When you look at that, there's no room. 4 incisors are going to fit in there. On the lower, look at the size of those central incisors. So if you see this, you can wait until disaster hits, and you're going to get your laterals on the palate or lingually inclined, and you're going to get cuspids coming in like fangs. Or you can say to the mother, look, let's develop the arch and let's avoid these problems. Let's make it easier on this little guy. So he doesn't ever need extractions, and he doesn't need a lot of ortho later. So poor cooperator gets this. This is a neat appliance developed by an orthodontist friend of mine in Scotland, Dr. Clark. And it's got a nickel titanium coil spring right here in the middle. All you have to do is cement this appliance in, and that little nickel titanium coil spring within that force module just expands about 1 millimeter a month. You don't have any adjustments to do. And the younger children like this better than that Hyrex screw that I showed you. So there it is, and you'll watch the distance between here and here increase. So this part doesn't increase, but from here to here increases, okay? So let's watch it. It's a comfortable appliance. We're going to start, because he's a young guy, we're going to do the top first, get him used to it, and then we'll do the bottom, okay? So just one tooth at a time when you're a little 5-year-old guy. Look at the difference here. Remember I showed you before we started, and look at how much that's expanded. That's probably expanded about 4 millimeters, and it was absolutely painless, and that's within about 2 months, 2 or 3 months. So there he is. Now we're making room for the two centrals. Now let's make room for the laterals. Just keep expanding. See how you've got a buccal overjet over here, so the upper arch is expanding beautifully. Now that he's used to that appliance, I'll put the lower one in. Okay? Again, there's the expansion after 3 months. It's painless. That expands painlessly. It doesn't hurt the patient at all. Now he's very crowded in the lower. Look, this lateral's coming sideways. There's no room for a lateral here, so what are you waiting for? Why would you wait? I mean, go in there and fix that now. He's 5 years old. He'll wear the appliance. If I can take an impression on him, I'll treat him. So there he is. So upper and lower appliances. I mean, they're very comfortable. There's the lower. There's the upper. Look, there's room for all the teeth now. We have room for the four central lateral incisors in the lower and the 4 incisors in the upper. So again, that's how we started, very crowded. And look at this. Now, nice. Now it did a little bit of a mark when it came out, but salt water rinses will fix that in about 2 days. But look at the beautiful lower arch we have now compared to this. Look at the little arch here. What about talking? He has no room for his tongue. What about crowding later? He's going to maybe have to have extractions unless somebody gets a hold of him and develops those arches. Okay? So, I mean, look at that. I mean, that's a beautiful lower arch. Now, he moved away, so I never got a chance to finish him, but boy, oh boy, look, I made room for that lateral incisor. Here, he had no room. Remember, 4 crowded teeth, no room. Put that upper appliance in that worked by itself. You didn't even have to adjust it. It's a self-adjusting nickel titanium cross spring, and we got room for all the teeth. How easy is that? There he is. There he is. Lots of room for lateral here, and hopefully if we move this central over here, we'll have room over here. So that's the last I have him, but I mean, I really helped him. I mean, that's the greatest gift I can give him, is to develop those arches with no discomfort when he's 5 years old and make room for all his permanent teeth. And hopefully, look, he's got a nice broad smile here. Hopefully he'll never need extractions, and he may not even need braces. So again, that's my number. Now, I went to Turkey, and I'm just showing you this because this is in Istanbul that had 20 million people. But what I want to show you, I taught my course over there, and I'm going to recommend that you take a course that offers you a certificate. So my course offers a certificate. It's 132 hours of CE credits, and get a certificate and take some course, and most courses do give you certificates. And make sure, like, you have to pass tests and bend wires and trace steps. Make sure it's a bona fide course. I mean, there's some courses out there that are weekend courses. I'm going to recommend against those. I'm going to recommend, you know, a course that's substantial. Okay, so that's my class over there in Turkey. But they all got certificates at the end. They had to do all their lab exercises and trace all their septometric x-rays and put the brackets on typodonts. And anyway, that's 2 orthodontists that ended up taking my course over there. And they were doing functional appliances. I was very impressed because in Europe, they do functional appliances. And the orthodontists do them and the GPs do them. Not so much in North America. Let's show you Kenzie here. I mean, this may be the last case I get to show you, and that's too bad. I got lots more, but here's Kenzie, 15 years old. Very narrow smile. What a shame. She should have been developed earlier, but it's not too late. It's got a very constricted arch. She's got a cuspid that's labally displaced. So have a look at this smile. Look at how the teeth are going in the upper and going in the lower. That's not a nice smile. Very pretty girl, a lot of crooked teeth. So go in there and develop the upper arch with that Hyrex appliance. Give her a nice smile. You have to develop the arch. You can't get that with just braces. You've got to use an appliance, in my opinion. You can't get 10 millimeters expansion with braces. Braces would probably give you 3 millimeters, but you need 10. And the lower arch, look how crowded this is. Look how crowded this is, and look at her tongue way back there. And look at this tooth all blocked out. Look at the crowding in the front. Again, that's the appliance we use in the lower. It's a fixed appliance with a nickel titanium coil spring there. We put that in, and we expanded 6 millimeters with that appliance. And so the upper expanded 10. And there's your smile, and that's your smile right after those appliances. No braces. Again, look at that smile. Look how narrow that is. And look at that. And look at the smile. Look how happy she is. I mean, she's gorgeous. And she's dating my receptionist's son. So I had to do a good job or I would get in serious trouble. So then we put the braces on. Put the braces on for probably a year. Wouldn't it be nice to expand the arches? And you can expand adults. You can definitely expand adults. Don't think you can't. Then I need a little more expansion in the lower because I got 10 on the upper. I needed more in the lower, so I put a little Schwartz appliance in with the braces to expand the lower. And then we just finished with straight teeth. Now, some of you may not have seen this, called a QCM retainer, which is really a nice retainer. And so that's something that a lot of us are using now because it's nicer than that Holly retainer with that labial bow. So patients will wear this retainer and they just love it. So there's the lower arch when we started. There's the lower arch when we finished. So don't think that those teeth are expanded out of the bone. Those teeth are beautiful, right over the ridge, just where they should be. And look at the tongue, how it's forward. Look how the tongue is back when you've got a narrow arch. Honestly, that is going to have a serious effect on patients with sleep apnea later on in life. This patient is probably not going to hopefully get sleep apnea because their tongue is forward. Because when the tongue falls back at night, that's what causes problems. So again, we always put a lingo bond retainer here at the end to keep all the teeth from relapsing. On the upper arch, we'll do the same thing. Look at that beautiful arch. Beautiful upper arch. Beautiful broad smile with a lingo bond retainer. So again, constricted arch, straight teeth, constricted arches, straight teeth. That's the one I like the best. Look at how much that is constricted. And just by developing the upper arch, no extractions. Look at the beautiful broad smile that you get. So you need to learn to use these functional appliances. And if you don't choose to do orthodontics, and some of you may not, please send the patients to someone who does it this way. If someone is taking out bicuspids in all your patients, say, I want to find someone who can do it differently. I think a lot of general dentists take my courses because they feel that whoever they're sending to now is not doing what they want. Here's the narrow smile. There's the broad smile. I mean, that is drop dead gorgeous. Narrow smile, broad smile. Do you think I changed her life? Do you think I changed her appearance to the point where everyone just wants to be with her and know her? I'm just going to end with this, okay? In Ontario, we just got a report that in the next 10 years, our practices are going to go down 25%. And they're saying right now in Ontario, 42% of the practices are not busy. And this is because the University of Toronto, for instance, and maybe the other dental schools are doing this, are increasing enrollment by 10%. The dental schools are bringing in foreign dentists who pay over $100,000 a year, so they want to bring in more foreign students because it's a business like any other business. Older dentists are postponing retirement like me. I want to keep working because I like working and I'm making money. And the dentist population ratio is falling. So we have to be aware of this. And the big thing is they're saying in Ontario, and I don't know about where you are, they're saying the net incomes are going to be decreased by 25%. My answer to that is be proactive. Maybe learn to offer early orthodontic treatment, or maybe you want to do implants. Maybe you want to do something else. I just know that during the recession of 2008, I had 2 dentists tell me that if it hadn't been for orthodontics, they feel they would have gone bankrupt. Because when people don't have jobs, they don't go to the dentist, but they always bring their children to the dentist for ortho. Corporate dentistry is here. It's in the States. It's in Canada. Look what happened to the smaller pharmacies. There's no more smaller pharmacies. 15 years ago, there were a lot of small pharmacies. Now there's none. These guys are going to be open 7 days a week. They're going to be open nights. They're going to offer all services. They're going to lower the fees. They're getting all kinds of new grads to work for less. They can get dental supplies at big discounts. They can offer lower fees. And they got a big, large marketing budget. So make sure you go with OfficeSite and make sure you're marketing your practice properly and market whatever you do. Look what happened to GM. They got complacent, didn't they? And now Toyota is the #1 car company in the world. GM said they didn't want to make small cars, and guess what? They should have, and now they are. So focus on building your practice, adding new services. In my opinion, mothers want early orthodontic treatment for their children. If you start offering that, you will not have to sell early orthodontic treatment. They will line up to get it. All you have to do is tell them, I've taken this course, I'm doing early treatment for children. If it's a difficult case, I'm going to send to the orthodontist, but I think I can do these simple cases for your children, and you can do straight wire and you can do functionals. So remember, more competition in the future, more dentists, lower fees, add new services. Remember, 70% of children have malocclusions, and most orthodontists in North America are not treating children mixed dentition. Now, it's getting better. More and more orthodontists are doing it, but I think it's an excellent opportunity for general dentists to help these patients and increase your income. So I guess that's my message tonight. I've got a lot more cases I'd love to show you, but time is up. And thank you for the opportunity. I hope I've stimulated you enough to, #1, maybe want to take a course from me or somebody else. And I hope it's a comprehensive course. I hope it's not a weekend course. And also think about marketing. Think about how you're going to build your practice. And again, I highly recommend OfficeSite. So I told them tonight, I told Don that not one person that's ever come to my course, has signed up with you, Don, has ever come to me and said, that was a mistake. Everyone is happy with your services. You're very professional, and keep doing good work because we need your help. So again, I guess that's it for me, and I'll be answering questions.
Yes, we're going to move right to the question and answer session right here. But definitely thank you very much, Dr. Rondo, for that those kind words. Lee, could you switch the screen, please? And also, so let's go ahead and let's look at some of those poll results, Dr. Rondo. So I'm going to go first, and I'm going to share the results for how often do you get requested for
extraction of
orthodontists to extract. Yep. So any commentary here?
I can't see the answer.
Oh, you can't see the results? So often was
No.
60%, and never was 40%.
Okay, well, that's good then. I mean, that's never means that there's a number of orthodontists then that are doing early treatment and developing arches. That's wonderful. And 60% are still taken up by cuspids. And I guess what are you going to do if you send a patient to an orthodontist or a general dentist that you might know, and he wants to take out teeth? My recommendation is try to find someone who maybe can do it without extracting teeth, because I've just shown you I take out very, very few teeth, especially if I can get the patient early enough. So my advice is either learn to do it yourself or find someone that can do your philosophy, whatever your treatment philosophy is. I'm hoping that, and I feel badly that most general dentists don't take courses in early orthodontic treatment. I think in South America and Europe, they learn how to do this. It's not that difficult to put an appliance in and turn a screw, or have the patient take it out and turn a screw, or even some of these appliances work without turning. They just work by themselves with the nickel titanium coil springs. It's not that difficult to develop arches. And the patient cooperation is very high. If they get a Schwartz appliance, they can't wear it, we give them a fixed appliance.
Great. The second question, do you offer Invisalign treatment, was basically a split. 51% said yes, 49% no. Any commentary on that, Dr. Rondo?
I think they all should take Invisalign. I think Invisalign is a nice way of attracting new patients to your practice. I think Invisalign is much improved. The material is much better. They've got little things that attachments that attach onto the teeth, and you can help move the teeth better. But I think a lot of dentists who take Invisalign end up taking my course or some other course, because Invisalign can't do everything. I think the other thing that's interesting is I have paid, the one thing I don't like about Invisalign is that if they can't expand the arches, they have to slenderize the teeth, take some tooth structure away. And so if the dentist learns to use a functional appliance to develop the arch and then does Invisalign, that's going to cut down the cost of the trays and cut down the treatment time and end up with a nice result. You won't have to slenderize teeth, and you get the beautiful broad arch they want. And wouldn't it be nice to put a Schwartz appliance in that nobody sees, and then do Invisalign, which nobody sees, and that would be the finished case. And I think the dentist can get well paid for that, because patients are paying big dollars for Invisalign cases. So I think Invisalign is a very good way to go, but I think it's nice also to take an orthodontic course in case you have to use functional appliances first, or what happens if you get a bad rotation and the Invisalign trays are going to take too many trays to fix it, whereas you can put the braces on and straighten the teeth in 3 months. We also have clear braces, which I didn't show tonight, but a lot of children and a lot of adults like the clear braces and will opt for that because it's less time than Invisalign. But I highly recommend they get into this. And the reason you got to do Invisalign is because patients are asking for it. And you should market that on the website. I mean, we're marketing that on our website, and they need to market that. I think ortho is a huge opportunity for everybody. I think if 70% of children have a malocclusion, and there's lots of adults that want straight teeth, and they all want Invisalign, I think it's a huge opportunity to increase the size of your practice. And also, what's really neat about it is the staff do most of the work. I mean, I have 7 operatories, and the staff are running those operatories, and I just go in and check in the patients and say you're doing a great job and go to the next room. I mean, that's why I've got so much energy at 9 o'clock at night, because I didn't expend any energy today. We saw probably 60 patients.
Perfect. So now we're going to jump over to the questions and answers. First question here is, at what age can you start ortho treatment?
Well, I can start some patients at age 4. If I see any kind of a problem, like a narrow arch, usually narrow arches or a habit are the 2 things I start early. So if the patient comes in and the mother is impressed, I mean, if I like the mother and she seems very responsible, and the child will allow us to take impressions, and we can soon figure that out, then I'll start at age 4. If not, I'll tell them, look, it's no problem. Come back when you're 5. Come back when you're a little older. Or 6. No problem. We can do it at 4, 5, or 6. And I think the ideal age would probably be, but the habits need to be stopped. Remember, I stopped that little guy at age 5. But if he still had the habit, if he wouldn't let me take impressions, I'd say, come back next year. We can fix it. Don't worry. But certainly the earlier the better. And it depends on the child. We can use fixed appliance or remove appliance. But start early. Don't wait until 13 until all the permanent teeth are up.
Beautiful. Next question is from Dr. Shen. It says, I just saw a patient 12 years old and looks like maxillary arch too narrow, edge-to-edge front teeth and posterior open bite, and tongue gets between the teeth when swallowing. How would you proceed?
Well, that's 3 different problems. So if you've got a narrow upper arch, you want to expand the arch. If the teeth are end-to-end, you want to bring the front teeth forward. I would use a 3-screw anterior sagittal. So it would have 2 screws at the back that you'd activate and would move the front teeth forward, and you'd have 1 screw in the middle to expand the arch. So a 3-screw anterior sagittal, or if he wants to make it less, and worry about that posterior open bite last, believe it or not. I mean, develop the arch. If you make room for the tongue by expanding the arch sideways and forwards, that open bite might close because the tongue will have room in the mouth to operate. It won't go out the side. So I would do either a 3-screw anterior sagittal, or if he wants to just do a Schwartz appliance and develop the arch, and then later put a screw in the front and move the front teeth forward. If his teeth are hitting, make sure he puts some pads on the appliance, because we don't want traumatic occlusion to damage those incisors.
Great. Next question is a clarification question from Dr. Meacham. Is that another type of Schwartz? And that was about around 7:15, so you're probably on slide 30 or 40, I imagine. Does that help?
That was a modification. That was called an anterior sagittal, because it had an anterior sagittal screw to get that 1 tooth out of crossbite. So Schwartz Appliance usually expands laterally, develop arches. If you want to go forward, you call it an anterior sagittal. If you want to go back, you call it a posterior sagittal. I didn't show any posterior sagittals tonight, but you can actually make an appliance and put the screw mesial to the molar, turn that screw, and the molar goes back. So there's lots of different appliances. I mean, really, you know, these dentists try to take some courses on functional appliances. You'll learn all kinds of different appliances, and they're so easy. The patient does all the work. They just turn the screws. You know, they're doing the work. I'm not doing anything. They just turn the screw, turn the screw, turn the screw, teeth move, arches expand. I didn't have a chance to show any class 2s tonight, but I showed you photos of those class 2s where we brought the jaws forward. But we used 2 appliances. Under age 11, we use a twin block. Over age 11, we use a kind of Mara appliance. Most of the functional appliances have been developed by orthodontists. And what's really interesting, though, most of the labs tell me most of their clients are general dentists. but it's getting better. More and more orthodontists are doing this, and that's great. I think we need to do what's best for the children. We need to get in early and treat early and avoid more costly problems later on. Get the malocclusion fixed early because it's only going to get worse.
Great. Next question is from Dr. Gillespie. Do you like to wait to begin treatment until permanent first molars erupt?
You don't have to. You can treat when there's deciduous molars, but probably from a patient cooperation standpoint, waiting till those first molars erupt and the patient's a little older, patient's around 7, that's probably a really good age. I would tell beginners to start with 8-year-old girls, because 8-year-old girls are so smart and they'll do anything you tell them. You explain to the 8-year-old girl, look, this is going to give you a beautiful smile. This is going to make you breathe better. This is going to make you prettier. This is going to mean we don't have to extract any of your teeth. She will wear anything. So if you want to start with patients, start with 8-year-old girls. Don't start with 14 or 15-year-old boys. 14 or 15-year-old boys are the toughest cooperators. That's why it's really good to get in early, because the children are good cooperators. Teenagers, a little tougher.
Beautiful. Next question is from Dr. Senderovich. How do you treat bruxism in kids?
Oh, that's a good question. The first thing you have to find out is why they're bruxing. Now, everybody thinks stress is a factor, and it is. I mean, if he's under a lot of stress in school or parents or whatever they're having problems with, I mean, they will grind their teeth. However, we're finding now that one of the biggest problems of bruxism is airway constriction, and I didn't have a time to talk about that tonight at all. But if you have large tonsils or large adenoids or you have allergies, they're going to brux, and they're bruxing to open up their airway because the tonsils are blocking the airway and the adenoids are blocking their airway. So they're mouth breathers, and they're trying to bring their jaw forward. So examine the tonsils, and of course we never did. We weren't taught to do ortho. We weren't taught to look at tonsils. We were taught to look at teeth and gums. Boy, if you get into looking at airways and breathing, I mean, I just had a patient come all the way from Windsor, which is a 2-hour drive, because the ENT specialist would not take out the tonsils. And this boy was wetting his bed. He's hyperactive in school. He had ADHD. They wanted to put him on Ritalin. And it was unbelievable. The mother somehow got my name, and I wrote a letter to the ear, nose, and throat specialist, and I gave references from the literature, and I sent photos of the tonsils, and I had these diplomats, I guess, which helped them a little bit, and they took him out. The girls couldn't believe it. She said, when he got your letter, and he got the picture of the tonsils, and he read your references, he took them out. He wouldn't do it for me. And now I just talked to and the child also had sleep apnea. They were stopping breathing at night. And now the sleep apnea is gone, and most of the bedwetting is gone. To be honest, there's still a little bit of bedwetting, so, but I'm hoping that will go away. But everything else is okay. He doesn't have ADHD anymore, and so airway is so important. And I think if I ask a question at the end of my course, what's the best thing you learned at my course? People say about airways, because we've helped our own kids. We've been able to get the tonsils out of our own kids, or get the adenoids out, or we've been able to look at the airway, and we've been able to develop the arches. So in answer to your question, do the diagnosis, see what's causing the bruxism, which many, many times is airway obstruction. And then, interestingly enough, how I treat it is I build up, usually if the teeth are worn down, I build them up with composite. I do composite buildups on the primary molars, and that helps a lot, because a lot of patients who brux are overclosed vertically because they've worn their teeth down. So check the tonsils, check the adenoids, check the nose, and build up those primary molars with composite. You will get great results. I'm sorry I didn't have a chance to show that tonight.
Hi, everyone. It is 8 o'clock. We're going to keep going because we got some great questions here, but if anybody needs to sign off, I just want to say OfficeSite is willing to give you a special gift tonight. For any new customers, we're willing to actually set you up with 2 months free of our web presence solutions for the website portion. So definitely reach out. You can email me, dmckenzie@officesite.com. Just make sure you put Dr. Rondo's name in the subject, Dr. Rondo webinar, or Don McKenzie. Put something in regards to the webinar, and we'll take care of you and make it easy on you. 30-day money-back guarantee. There's no risk. We're going to take good care of you and help you feature those services and new services in your local community. So at this point, let's continue with the great questions. I have a bunch here.
Now, one quick thing, Don, is that I'm not offering any discounts tonight, but I do offer a money-back guarantee. So if you take my course and you don't like it, you'll get your money back, no questions asked. But I don't offer a discount tonight. I didn't think of it, I guess. But anyway, but I do offer a money-back guarantee. I think that's really good because, and I haven't had to do it for many, many years, but nobody's perfect. Carry on.
Well, we actually do have a couple course-related questions for you.
Sure.
I'm combining questions from a few different doctors. Dr. Shen Dahan says, your online course, anything hands-on? The second portion is, what do you consider a comprehensive course? And
well, I think my course is comprehensive because we have dentists starting cases as soon as they finish the course. And the other interesting thing is, I mean, and Lee tells me, and I find it hard to believe, that people take the online course. And my online course, you watch 20 minutes, and then you have 10 questions you got to pass. If you don't get 80%, you have to watch me again, and most people don't want to watch me again. They want to watch the next 20 minutes, and then we can give you CE credits. I think my online course is 1,500 questions. And they learn to bend wires online. They learn to put brackets on teeth, and they have to take pictures and send them to us. They learn to trace cephalometric x-rays. And Lee tells me she's got all kinds of dentists that never came to the live course, that just on the online course, they're starting cases. So, I mean, it's interesting. I also have level 2 courses after my level 1 course is over, which is 4 days. And also you can repeat my course at half price, or if you bring someone, you come at free. I really think my manuals are about 300 pages each, and you get 4 of those. You read those manuals, and you pay attention to the 8 days, you can start easy cases. We're not trying to teach you to be orthodontists here. We're trying to teach you to diagnose and treat the easy cases, especially the children, and the easy straight wire cases, and refer the rest out to the specialists, because we still need our specialists, and we still want them to do the difficult cases. We want to do the easy cases. That's the way all of dentistry and medicine is supposed to work.
Great.
I can give references too. I would think if they wanted references, I mean, we'd be happy to give them references. We've got, well, I think I've trained 9,000 dentists in 35 years. So we've trained a lot of dentists. So, or maybe 9,000 have come to my seminars and taken my course. Anyway, it's a large number. I mean, we'd be happy to give you, dentists you could talk to and ask anything you want, and they'll tell you the truth.
You know, a couple of people asked about the CE. After the session, I'm going to go ahead and send out an email with the test. And it's got instructions. You're going to basically fax it back to Lee at rondoseminars.com, and also, or you can fax it, or you can email it back to her via scan email. So let's go ahead and we'll keep it going. Is there an age limit for you? One quick thing,
on, like, my course gives you 52 hours of CE lecture and 72 hours hands-on, because you have to do a lot. You have to take records on 5 patients in your office, complete records. We show you how to do that. You got to trace 15 cephs at home. So there's a lot of things you do at home, and therefore, for people going for their mastership in AGD, we give 72 participation hours in all different things. And so that's kind of neat. A lot of people like that because they want to get their mastership in AGD. So it's, I think it's but there are other comprehensive courses too. You go online and find a bunch of, I do like the fact that we do functional appliances. We do straight wire. We teach a little bit about the TMJ, half a day, and we do a little bit on snoring and sleep apnea. So you kind of put the whole picture together, I think, and airways and breathing, and I think it's, I really like the way I've structured the course, and I really find my course manuals have cases from start to finish, and I think it's an easy way to learn. But you got to spend some time. You can't just come to the lectures. You've got to read those manuals, and you got to start some simple cases. You don't learn to play tennis reading books. You learn to play tennis by hitting the ball over the net, and you got to start some easy cases.
Beautiful. Dr. Seigel is wondering, is there an age limit for using the Schwartz appliance?
No, there's not. It's amazing because there's a lot of articles been written and say that you can expand a non-growing patient. But I've been honestly doing it for 35 years, I can tell you there's about 4 or 5 patients in my whole life I couldn't expand. And so sometimes if the patient been in a car accident, the sutures are locked, and when you start using the appliance, the teeth will flare. Okay, now if you look carefully at those cases I showed you, there's no flaring of teeth. And so on about 4 cases, those patients said it hurts, my teeth are flaring, I couldn't do it. But 4 cases out of thousands. I mean, I don't know if I've treated 20 or 30,000 patients, and I probably developed most of them. Because the step one for me is to give everybody a proper size maxilla. I actually think it's the key to total health. If you ask me what's the most important thing you teach, I say give everybody a proper size upper arch as early as you can. It opens up the nasal airway. It helps you to speak. It makes room for all your teeth. It makes room for your tongue. I mean, it's the most important thing. And then many times when you develop the upper arch, the class 2 corrects because the lower jaw comes forward to its proper position. So it's amazing. Now, we develop adults, and you can talk to the labs that I work with because I work with some very good labs who've been doing this for 25 or 30 years. And they will tell you that they have a lot of customers, a lot of dentists that use arch expansion appliances very successfully. So you definitely can do it. But you might get 1 case in 1,000 that hurts and then just stop. But boy, I don't even tell the patient anymore because it's so rare. You can definitely do it.
Hey, Dr. Rondo, how much more time do you think you have for questions?
I'm fine. I'm here. I have no bus to catch. I'm fine. I'd be happy to answer questions. I mean, I really want dentists to get this and learn that they just need the education. I mean, in my opinion, I think we were neglecting. Nobody learned about practice management in dental school, and yet we have to go out and borrow. Most of us were in debt by $300,000 or $400,000, and then we got to go set up a practice and no idea of business. It's ridiculous. And you can really help with that because you can help them market their practices. And we learned nothing about TMD. We learned nothing about orthodontics, and yet we're supposed to refer out and do these things that we don't even know what we're talking about. And so it's a shame. I think some dentists seriously have taken my course. I don't want to do it. I just want to learn about it so I'll know where to send my patient, and that's okay. But most of the dentists, at least 80%, will actually start cases and they'll start helping their younger patients, particularly. We get them to start with the children. Start with the functional appliances. Just put these appliances in and watch them work. And then learn to put a few brackets on and put some brackets on and gradually get into it. And really encourage them to have their staff take the course, because when the staff takes the course, they're all fired up. My hygienists find a lot of patients for me. They just see the patient with a malocclusion, they mention to the mother says, great, let's book an appointment, and then they come. So it's really a team game, and if you go in most orthodontic offices, you'll see a lot of staff working hard and doing a lot of the work. That's what I like. I mean, dentistry to me was pretty difficult. I mean, it's hard work. I used to get tired at the end of the day. I'm not tired now. I don't get tired doing ortho. Staff are doing most of the work. And you know what I like too? I get thanked. Thank you, Dr. Rondo. My daughter has a beautiful smile. Thank you, Dr. Rondo. She has no more headaches. Thank you, Dr. Rondo. We don't need any more extractions. We were told surgery, and you did without surgery. We were told extractions. You did it without extraction. Thank you. I like being thanked. I'm at the point in my life where I like to be appreciated. And I think when you do orthodontics, especially on children, you'll be appreciated.
Question from Dr. Raghavan. How does nickel titanium spring expand?
Well, the nickel titanium coil spring is compressed. So you take maybe a 12 millimeter nickel titanium coil spring and compress it down to 4 or 5. And then the minute you put it in, you have to tie the appliance together with stainless steel when you're inserting it. And you cut the stainless steel, and the nickel titanium coil spring just expands. And expands about 1 millimeter a month, painlessly. It's fantastic. I mean, and I only showed you, I think, one appliance with a nickel titanium coil spring, but we've got all kinds. I've got nickel titanium coil springs that'll move the maxillary teeth forward. I've got them that'll move the molars back. I've got them so they'll expand. I mean, they're just fantastic appliances. We call them fixed functional appliances. And I mean, even Invisalign is wanting the class 2 fix first. And so they've got Actually, they've got an appliance they're recommending now called the Motion Appliance, the Carrier Motion Appliance, which I'm going to be featuring in Las Vegas. Dr. Carrier is coming over from Spain to show that appliance. But it's something that goes on the upper cuspid, the upper first molar. It's a bar, and then you put a lingual arch in the lower, and you put a bracket in the lower molar and a class 2 elastic, and it moves the molars back from class 2 to class 1. And they want that done before you do Invisalign, because it's hard to correct a class 2 molar relationship with Invisalign, because Invisalign basically straightens the teeth. So if you don't do that, then you could use an appliance to distalize the molar. So I really think if you want to do Invisalign, if you want to do proper orthodontics, you should know how to do arch development, distalize molars, move the front teeth forward, do Invisalign, and do braces. If you can do all those things, you'll get a great result for your patient. You'll be busy. We're busy. We have about 5 new patients a day, and you're partially responsible for that because we had a lot on the website, a lot coming in, with our website. But I mean, dentists need to be aware that the future, unless you prepare for it, may be a problem. Because if they're talking about my income going down 25%, I'm going to tell you it's not going down 25%. I'm going to work hard to make sure it doesn't. And dentists need to look at new things. Now, tonight they're looking at ortho. Maybe they want to look at implants. Maybe they look at... The thing I like about ortho is that the mothers want it, and they will find the money to treat their children. And all of the dentists know that have children out there, they will do whatever it takes to make their children look good with straight teeth. I mean, they'll find the money for ortho. They'll find a grandmother. They'll find somebody that'll put money into ortho for their children, for their smiles. I mean, it's just number one. And it's amazing how many mothers find me well, of course, the marketing helps. But mothers find me and they say, I went to an orthodontist or I went to a general dentist, they want to extract teeth. Because general dentists take them out too, right? I mean, it depends how you're trained. And they come to me and they say, we've heard you don't do extractions. And I said, you came to the right place. Let me have a look. And boy, if I get those, I mean, I so rarely have to take out a bicuspid, I can't remember the last time I took out a bicuspid, So, I mean, we just develop it, but I need the appliances. I can't do it with braces. I need those appliances, and I showed you some of them tonight. The combination of functional appliances and braces makes the fact you don't have to extract teeth. And people, that's what they want. They don't want surgery. I showed you some of those cases where the patient had underdeveloped lower jaws. I put an appliance in for 7 months, brought the jaw forward without surgery. That's what mothers want. That's what they want. So we have some before and afters on our website. We're actually you're just revising it for me. And we're putting up a lot more before and after. So maybe another couple of weeks would be better time to look at the website because we're putting all new pictures up there. Next question.
Yeah, and we have several. So I don't know if we're going to get to all of them. So we'll do a couple, and then the questions I can't get to, I'll give to Dr. Rondo, or definitely reach out to him and Lee and get those questions asked and answered. We attend all those sessions, and it's very popular. Lots of consistent attendees and all over the country, convenient locations. Anyway, Dr. Eco is curious, with significant expansion, are you not concerned about violating the neutral zone? Do you have any CT images to show bone remodeling? And how do you mitigate the imminent recession and abfraction that can occur?
See, I find, honestly, now let's face it, if you had a patient who had a dolichocephalic, long, narrow face, and really narrow, you'd have to be careful how much you expanded. And if they had really tight cheeks, I mean, you'd have to take that into consideration. But it's amazing. I mean, I just don't have, and I don't have the CT scan in my office. But I mean, I would have known by now, having done this for 35 years, if we started getting problems, I'm sure I would have been the dentist, because I don't do general dentistry. This is all I do. But the general dentist would have sent the patient back to me and said, look, this is not good. So I don't think you have to worry about that, because remember, what you're doing is you're opening the midline suture. It's a bony change, right? You're turning the screw, and the midline suture, the mid-palatal suture, is expanding, and it fills in with bone. It's an orthopedic permanent change. And as long as you don't expand too much, and honestly, when I expand enough just to get the laterals and centrals in, then I stop. And I'm just not having that problem. And we're just not getting the abfractions. We get abfractions from bruxism. If there's bruxism, we get abfractions. And those patients usually have sleep apnea and they're snoring. And then we fix the airway, fix the bruxism, and hopefully stop the abfraction. So I'm not getting abfractions from expansion. I just have not seen that because I guess I don't overexpand. I think the concept you have to get used to is you're taking a narrow pathological arch and make it normal. And I tell my patients, I'm taking a narrow arch and make it normal. I'm not expanding past the physiological limit. And for sure, you're right. You have to make sure you don't push into the cheek. But I find if I just, it's such a simple rule, develop the arch to normal. Take a pathological arch, develop the normal, make room for four incisors. That's it. Just do that and stop. Now, having said that, you got to hold for 6 months. When you develop the arch, you have to hold for 6 months. And then if the patient is a nasal breather, you won't get a relapse. If the patient is a mouth breather, the arch will collapse. So it's very important to look into the airway and the breathing, and of course that's an important part of any good orthodontic course. It's not been a problem for me.
Yeah, just to make it clear, this is bonus time, so if anybody you don't have to stay on at this point, but we're going to get a couple more. We'll do 2 more questions, Dr. Arando. A couple are related to adults. Which will arch expansion work in adults? And then also the related question was, does it take longer to gain expansion in an adult patient using a Schwartz appliance?
I actually still turn it twice a week. I told you what I do is I tell the adult, if this hurts you, stop turning or go once a week. But I just don't get them. Like the suture is not closed when you through growing. The suture's open. You've got 32 cranial sutures which in the skull which are open. And the only time they're closed when you die. So, or if you're in a car accident or some trauma, sometimes they'll close. But otherwise, we do adults all the time. I mean, I get a lot of my practice is a patient comes in with TMJ problems. I'll put 2 splints in, a night splint to stop the bruxing and a day splint to move the jaw to the correct position. And then 90% of them go into ortho. Maybe 10% have crown and bridge or something else done or stay with their splints, but 90% go into ortho. So I have to develop those arches in all those adults, and I do it all the time. And what you need to do is go talk to a lab. Go talk to a lab that makes functional appliances and just ask the same questions you're asking me. And those lab owners will tell you, we just don't see those problems. Because if they did, we would certainly stop doing it. I mean, if I started expanding adults and they all relapsed, believe me, after 20 or 30,000 cases, I don't know how many I've done, I mean, I would know it. And I would not keep doing it. I mean, I'm not going to keep developing arches if it doesn't work. Because they're all going to come back and teeth are going to be crowded and they're going to be upset with me. It's not happening. It's not happening. You need to make room for the tongue. You need to give everybody a proper size arch. Remember, you're taking a pathological narrow arch and make it normal. You're not really expanding. It's a concept which, we're so used to looking at crooked teeth and saying, oh, there's no room. Well, there is room, but you got to make it. Sometimes you can go sideways, you can go forward or back. You can make a lot of room. Next question.
Perfect. Yeah, this is going to be our closing question. If you could, for us, in one sentence, or maybe a couple sentences, Dr. Arando, what is your closing message? What's your big takeaway?
I guess my big takeaway is I think we have to be proactive. We have to think that in the future we're going to have fewer patients because of competition from more dentists and competition from these corporations. So what are we going to do to make sure we're going to be able to pay our bills in the future? And the time to move is now, not when you're going down. Do it now because you've got some money to take some courses. You've got a successful practice and you want to keep it cooking. And so I think marketing, and of course I'm going to recommend you for marketing. I think you've got some great ideas. Make sure you get all your website on the mobile devices, because right now if you don't have mobile, if you're not mobile friendly, Google is going to put you in the back. They're not going to put you anywhere near the front page. And look at ortho as a possibility of first of all making you feel better about your practice, and also you've got all those patients in your practice. 70% of those children have a malocclusion, and all you have to do is get the skills to treat them, and the mothers will pay for that. They'll pay for the ortho treatment long before they're going to pay for an implant or a crown and bridge if there's a money problem. And so be proactive. Sit down. I mean, it's ridiculous. I'm 70, almost 73, and I have a meeting every week with Rondo seminars to figure out how we can build a practice with my ortho practice and with my general practice. I have a general practice I own 48% of with 4 dentists. And we meet every week to talk about how things are going. And I can tell you the practices are up since I started doing that on a weekly basis and solving problems on a weekly basis. So get proactive, get your staff involved, start thinking about how to build a practice and come up with ideas and take some additional courses and whatever interests you. But the ortho seems so easy and seems to be so appreciative that I highly recommend you look at some ortho courses. I guess that's my message. I mean, look to the future, get proactive, and get that practice cooking. So you don't have to look back 3 years from now and say, gee whiz, I wish I'd done that. Now we don't have very many patients and having trouble paying my bills, and you don't want that, because actually I think if the dentists that signed up tonight are probably the ones we shouldn't be talking to, because if you're smart enough to sign up for a webinar in the evening, you're probably got a very successful practice. It's probably the dentists, Don, that didn't sign up for the webinar that need to take my advice. So again, thank you for giving me the opportunity. I loved I just got back from the CDA convention, California Dental Association convention. I had 250 people in my room, 50 people trying to get in. It was a great experience. Then I went on and spoke at the American Academy of Cosmetic Dentistry, and I had a full house there too. I think ortho's time has come. I think that people have got other phases of dentistry figured out, and now they're looking for other ways to build their practice. And I think this is such a neat way to do it. So I'd love to have any of you take my courses. Go on the website and check them out, and love to have you come and meet with you anytime. And we'd have study clubs afterwards that help you with cases. I have an online study club. You can send your cases in. We'll help you with your cases for a slight fee. We have advanced courses after the beginning courses. I think it's a whole program that I hope we can help every one of you that wants help.
Beautiful. Well, thank you very much, Dr. Rondo, for the great information, the foresight, and the opportunity to learn more. Also, special thank you to Lee Larstone for her efforts in putting this session together. It was a great event, and we appreciate you coming out here tonight and showing your dedication to continual improvement. With your new insight, you now have a great opportunity to enhance your practice and your patient experience for today and tomorrow. To get your CE credit, I'm going to go ahead and send you that email. If you want to claim that webinar offer, just email dmckenzie@officesite.com, promo code webinar, and I'll have a web presence advisor reach out to you ASAP, and we'll really take care of you. But with that said, on behalf of OfficeSite and Rondo Seminars, thank you, and the webinar is now concluded.
Thank you, Don. Thank you, everybody.